very good afternoon to all the participants of this virtual online training program. I started my lecture today morning, but due to internet interruption, I was unable to complete it. So I hope I may be able to complete in this session. I'm going to present the basics of radiography and ultrasonography in veterinary practice. Since this lecture will help you in the coming program whenever there is the diagnosis of various affections using these two modalities, that is X-rays and ultrasonography. So start with the history of X-rays. The X-rays were discovered by Wilhelm Conrad Röntgen in 1895. He was a German physicist who was born in 1845. He discovered X-rays accidentally while conducting one of his experiments. He was experimenting whether the cathode rays will pass through a glass tube or not. In that very experiment, he discovered a new light emerging from a fluorescent material, which he didn't know at that time. So he named it as X-rays, that is unknown rays. He presented his findings of these X-rays before the World Society in 1895, for which he received the Nobel Prize in 1901. Since the discovery of X-rays in 1895, these rays have been used extensively in medical imaging for the diagnosis of various ailments in humans as well as in veterinary medicines. Now, the content of basics of radiography will include production of X-rays, principle of radiographic positioning, and radiographic interpretation. Now coming to the production of X-rays, the X-rays are basically generated in a X-ray tube. This X-ray tube is enclosed in a radio opaque material, that is lead casing. It basically has two parts, that is cathode and anode, which are cathode is highly negatively charged and anode is highly positively charged. Cathode has a tungsten filament and a focusing cup. This is the tungsten filament and focusing cup. The second one is the on left side is the anode, which contains a target material which is made up of tungsten, which has high atomic number, and whenever the high speed electrons strike at this tungsten target, the X-rays are produced by various subatomic interactions. Now these X-rays exit from an aperture on the ventral aspect of a glass tube, and then they interact with the body tissues, and the photographic record of the interaction of X-rays with the body tissue is recorded on the photographic film, which we commonly known as X-rays. Now next is about the X-ray machines. The basic component of X-ray production is the X-ray tube. These X-ray tubes are supplied with high voltage current and the basic control unit. The machines are of different voltage capacities. The first picture on the left side is of a portable X-ray machine, which has the capacity of 15 to 35 mA and voltage of 70 to 110 kilovoltage power. This is basically used for the making X-rays of extremities of large animals. The second machine on the right side is the fixed ceiling machine, which is used for mainly for large animal radiography. It is a high power X-ray machine. It can move on the horizontal axis as well as on the vertical axis. It can reach up to the ground and up to the roof of the room. Now this is the commonly used X-ray machine which we use for the small animals. It has a patient table. Underneath is the grid. Underneath is the cassette holder where cassettes are placed, and this machine is used most commonly for making the radiography of dogs, cats, and small ruminants. Now, the output of an X-ray tube is often described by the three terms, that is quality, quantity, and efficiency. Quality is basically determined by the penetrability of the X-ray beam which has been generated in a X-ray tube. The penetrability means the X-ray should pass through the tissue which is exposed and they should reach up to the cassette to make the photograph of the part being radiographed. Now next is the quantity. Quantity is the number of protons comprising the beams. The more is the number of protons, the more is the power of the X-rays. Another thing is the number of photons are of different energies. High energy photons are mainly responsible for the production of a X-ray image. Now next is the efficiency. The ratio of output energy as X-ray input energy is deposited by the electron. This is the mere ratio of input energy to output energy. Basically the X-ray tube converts electrical energy into X-rays. And we say the 99% of the energy is wasted as heat and only 1% of the input energy is reproduced as X-rays. Now next is the quality of a radiograph. Now X-rays are produced, they have passed through a part to be exposed. Now they have reached the photographic film to produce a image. Now the quality of this image is very important to give the diagnosis or for the interpretation purpose. The purpose of radiography is to obtain as accurate image as possible of the structure being radiographed. The three main visual components of a good quality radiograph are excellent detail, correct density, and proper scale of contrast. In the present slide, I have depicted two pictures. The picture on the left-hand side is of good quality and the picture on the right-hand side is of poor quality. You can well appreciate the outline of the structures being radiographed in both the pictures shown. Now next is the detail. Detail means the degree of sharpness or definition of an object on a radiograph. That means it should display the outline or contour of the organ being radiographed. Detail is good if the structural and contour lines of the object are sharp. Now in the two radiographs shown in the slide, the radiograph on the left hand side shows clear detail of the abdominal organs. You can well appreciate the intestines, liver, kidneys, as well as the pylorus of stomach. In the second radiograph, the detail of the abdominal organ is completely lost. It may be due to fault radiographic exposure or due to some disease condition. In the present radiograph, this was a case of ascites, and in case of ascites, the detail of organs is completely lost. Next is the radiographic density. Radiographic density means the degree of blackness on a processed film and is directly related to the number of X-rays reaching the film. Basically, radiographic density is inversely proportional to the subject density. That means if a tissue or part being radiographed is more dense, it will absorb more number of X-rays, less number of X-rays will reach up to the photographic film and the image will appear white. And if more number of X-rays reach up to the photographic film or X-ray film, the image appear black. The main densities which can be appreciated on radiograph are metal, mineral or bone, which appear white as they absorb more number of X-rays and they will allow minimum number of photons to reach up to the photographic film to interact and create a picture. Next is the fluid or soft tissues. They will absorb some amount of photons and will allow some amount of photons to reach up to the X-ray film. Fat will absorb less than the soft tissue and gas will absorb less than all others and it will appear black on a radiographic film. Next is the density. As I told, the density is inversely proportional to the tissue density. Radiographic density is inversely proportional to the tissue density. The tissues are material which are densely packed. They will allow minimum number of photons to reach up to the X-ray film and the image will appear white. In this particular picture, we can well appreciate that air will allow maximum number of photons to reach up to the photographic film. So it will show a black image. Fat will allow less number of photons than air to reach up the photographic film. So it will appear lighter than air. Water will allow less number than the fat. It will appear more lighter on the radiographic film. Bone will allow minimum number of photons to reach up to the photographic film. So it will appear lighter than water or soft tissue. And metal will block almost all the photons, and minimum number of photons will reach up to the photographic film. So it will appear completely white on the radiograph. Now next, this is the radiograph of abdomen of a dog. You can well appreciate the different densities. A is the metallic density, which is appearing white. It means it has blocked all the photons. B shows the bone density. It is lighter than the metallic density. C is the density of soft tissue. It has absorbed less number of photons than the B. D is of fat tissue density, and E is the air density, that is completely black. Now the radiographic contrast. Radiographic contrast is basically the difference in various densities of adjacent areas on a radiograph. It appears as differences between blackness, grayness, and whiteness due to variation in the subject densities, and enables the radiologist to interpret diagnostic information contained on a radiograph. A good quality radiograph has maximum number of densities, or we can say low or long scale of contrast. It should depict gray, light gray, dark gray, white, black. Another is the high or short scale of contrast. High or short scale of contrast radiograph will show only two densities, that is black and white. In high or short scale of contrast, the minor density differences in the soft tissues cannot be appreciated. So it is not required, for especially for abdominal radiograph to be of diagnostic significance. They should have low or long scale of contrast. Now this is the radiographic image. On the left side, the image has high or short scale of contrast. It has only two densities, black and white. On the right side, the picture has long scale of contrast. You can well appreciate the different soft tissues. Now again, high contrast and low contrast comparison. Now exposure factors. Whenever we take a radiograph, how much exposure should be given? Actually, the exposure factors are given as exposure factor charts with every machine, but for every machine, we have to recalibrate those exposure factors at our institutions depending upon our exposure of the part to be taken, depending upon the processing solution material, and depending on other factors. The general rule to calculate exposure factor has been given by a scientist called Sante's formula, in which we can calculate the KVP, which is the 2 times the thickness of tissue to be radiographed plus the SID. SID is the source image distance, or distance from the glass tube to the radiographic film, or you can say FFT. That is generally kept constant in case of veterinary patient, that is 90 centimeter, or you can say 40 inches plus grid factor whenever the grid is used. And for the calculation of MS, the thickness of tissue divided by the 2.5. From this formula, we can calculate the exposure factors to be applied when a part is to be radiographed. Now the radiographic positioning. Now, as advocated by the American Committee of Veterinary Radiologists and Anatomists, certain abbreviations are given which are followed all over the world and are common. We write D for dorsal, V for ventral, LE for left, RT for right, M for medial, L for lateral, CR for cranial, CD for caudal, PA for palmar, PL for plantar, R for rostral, and O for oblique. Basically, these terms, whenever we write about the exposure to be taken, we use these terms. These terms depict the direction of X-ray beam. Like in VD radiograph, it will depict the X-ray beam will enter from the ventral side of the patient and exit from the dorsal side of the patient. We can also take the oblique radiographs. For oblique radiography, we must mention the angle of obliquity. For example, O60L, it means the radiograph is of oblique. It should be 60-degree lateral so that the beam should exit from the palmomedial aspect of a limb. Now, the factors to be considered during radiographic positioning. The basic purpose of radiographic imaging is to obtain as accurate image as possible of the part to be radiographed so that we can have a diagnostic radiograph, for which the area should be well immobilized. The animal should be properly restrained before, and the animal should not feel any discomfort, and it should be comfortable to the patient. There should be minimum trauma to the area of interest, especially in case of fracture cases. We must take the radiograph so that there should not be an additional trauma to the limb being radiographed. Then minimum exposure to the assisting personnel. As we all know, the X-rays may cause radiation exposure. So exposure to the additional personals like our technicians or supporting staff should be kept minimum. For that, we must use the cassette holders. Now about the positioning guidelines. The basic purpose of positioning or making a radiograph is to obtain as much area as possible, and the central X-ray beam should be kept in the area of interest. For example, if we need to take a radiograph of lateral abdomen in case of a dog, the central beam should be centered over the caudal border of 13 dip for an abdominal radiograph so that it may incorporate whole of the abdominal cavity. Now, for limbs or extremities or for the X-rays of long bones, we must include the shaft as well as the proximal and distal joints. For joint radiography, the central X-ray beam should be focused in the center of joint, and it should include the proximal as well as the distal bone making the joint. Now, about the radiographic positioning of different parts. If we position the part to be radiographed in a proper way, then only we can get a diagnostic radiograph. Now we'll start with the forelimb. In forelimb, we do not go for the radiography of scapula. Sometimes we go for the radiography of shoulder joint. It is not very common, but we can take a mediolateral view of the shoulder joint. From this picture, you can this mediolateral view of shoulder joint can be taken in standing position as well as in recumbent position. If the patient is in recumbent position, the cassette should be a load bearing cassette and it should lie beneath the shoulder joint to be radiographed, and the affected limb is downwards towards earth and it should be pulled cranially. And in standing position, the cassette should be on the lateral side so that the beam will enter from the medial side of the joint and exit from the lateral side and interact with the X-ray film. Now for the humerus, we also take mediolateral view in the same way as we take for the shoulder joint. Next is the elbow joint. For elbow joint, we can take craniocaudal as well as mediolateral views. For craniocaudal view, the patient is restrained in normal standing position. The limb is pulled cranially. The cassette is placed on the caudal aspect and the X-ray tube is placed on the cranial aspect so that the beam should enter from the cranial aspect and exit from the caudal aspect. For the mediolateral view, the animal is restrained in standing position with the limb pulled cranially and the cassette is placed on the lateral aspect of the elbow. Next is about the radius and ulna. For radius and ulna, we can also take craniocaudal view and lateromedial view or mediolateral view, whatever is possible. For craniocaudal view, the cassette is placed on the caudal aspect and the X-rays are focused from the cranial aspect of the bone. For lateromedial view, the cassette is placed on the medial aspect and X-rays are focused from the lateral aspect of radius and ulna. For the radiography of radius and ulna, we must take a large sized cassette and X-ray film so that we can include the elbow joint as well as the carpal joint. Now about the carpal joint and foot. For the carpal joint and the bones beneath it, that is metacarpal, we take dorsopalmar or lateromedial or mediolateral views, whatever is possible. Ideally, we should take two views, VD as well as the lateral views. For the radiography of fetlock joint and digit, the foot is raised and rested on a wooden block. We can also take the flexed lateral radiograph of carpal joint as well as the fetlock joint. For the metacarpus, we can take dorsopalmar and lateromedial views, which are depicted in the below pictures. Now, fetlock joint and digits. For the fetlock joint, we can place the joint on a wooden block to raise it so that we can place a cassette behind it or besides it. For the first picture depicts the dorsopalmar view of the fetlock joint. The second picture on the left depicts the position for the lateromedial view, and the third picture is for the radiography of third digit. For the first phalanx and second phalanx, we can take dorsopalmar and lateral medial view, but for the investigation of the third phalanx, we must take oblique dorsopalmar views, in which the angle of obliquity is 45 degree to the earth, and we use the weight bearing cassette. Now for the hind limbs, normally the radiography of hip and femur is not done in case of large animals, but we can do the lateral as well as VD radiography in small calves or in small ruminants. For the radiography of hip joint, we need to place the animal in ventrodorsal recumbency. A large sized weight bearing cassette is used. The X-ray tube is placed on the ventral aspect and the X-rays are exiting from the dorsal aspect of the body. For femur, we can take the mediolateral view with use of weight bearing cassette placed beneath the animal. The affected limb is towards the floor. Now for the stifle joint, we can have caudocranial view as well as the lateromedial view. For the radiography of limbs as well as abdomen, in case of large animals, all the exposures can be made in the standing position, whereas in case of small ruminants or small animals like dogs and cats, the exposures are generally made in recumbent positions. Now for the stifle joint, for craniocaudal view or caudocranial view, the cassette is placed on the cranial aspect and the X-rays are focused from the caudal aspect. For the lateromedial view, the cassette is placed on the medial aspect and the X-rays are focused on from the lateral aspect. Now for the tibia, we can have caudocranial view, that is the cassette is placed on the cranial aspect of tibia and the X-rays are focused from the caudal aspect. Whereas for the lateromedial view, the cassette is placed on the medial aspect of tibia and X-rays are focused from the lateral aspect. And all these radiographs are, all these exposures are made in standing position only. Now for the hock joint, metatarsus, fetlock joint and digits, dorsoplantar, lateromedial and mediolateral projections are made as we do for the carpal joint, for metacarpals and phalanx in case of forelimbs. Now for the radiography of skull. Generally the radiography of skull is not done in case of large animals, but we can take the radiograph of mandible, turbinates, pharyngeal region and frontal sinuses. For the exposure of mandible, we can have, mandible has two parts, you all know, rostral part, rostral horizontal part and caudal vertical part. For the rostral part, we can have dorsoventral view. In the first picture, this is the dorsoventral view for the rostral part of mandible. In the second picture is a lateral view of the mandible, and we can also have intraoral views where the cassette is placed after opening the mouth and exposure is made from the ventral aspect. Now horizontal view of the caudal part of mandible. The third picture shows the horizontal positioning for the caudal part of mandible, that is the vertical ramus. Now about the radiography of vertebral column. Normally, the radiography of vertebral column is not in case of adult ruminants, But we can take the radiograph of vertebral column of young animals. Generally, we take only the lateral radiographs of cervical, thoracic, lumbar, as well as the coccygeal vertebrae. Now, these two radiographs depicts the radiography of thoracic vertebrae, lateral radiography of thoracic vertebrae, and the second picture depicts the radiography of the lumbar vertebrae. Next is the cervical region. In the cervical region, we can have lateral view as well as the dorsoventral view. And for the radiography of the coccygeal vertebrae, we normally take only the dorsoventral view. Now, in thoracic region, generally to radiograph a complete lung, we need 4 radiographs in the cranial portion, craniodorsal portion, in the caudodorsal portion, cranioventral portion, as well as the caudoventral portion. But generally, we take only 3 radiographs of craniocaudal, craniodorsal, and the vertical ventral portion, which completes the lung in the thoracic cavity. The radiograph of thoracic spine and lungs are taken in normal standing position. For cardiac radiography, the animal is placed in left lateral recumbency with thoracic limbs extended forward. Now, the first picture depicts the radiograph for the lungs, lateral radiograph. In the second picture is the positioning for the cardiac radiography, where the animal is restrained in the lateral recumbency and the cassette is positioned about 12 to 15 centimeter above the sternum vertebrae at the level of the central. X-ray beam is central at the level of 6th and 7th intercostal space. Now, abdominal region. Normally, we do not take the abdominal X-rays in adult ruminants, but we can diagnose the disorders of reticulum using the abdominal radiography. For that, we take the X-rays of the cranial portion of abdomen only, that too the lateral view only. Now, in the pelvic region, normally the pelvic region is not radiographed in case of ruminants, but we can take the VG view in case of small ruminants as well as in the calves. Now, about the radiographic interpretation. Basically, what I already told, that radiograph is the photographic record of extent of permeability of X-rays through the exposed body part. The radiographic interpretation is translation of radiographic image into an explanation of the pathology underlying the abnormalities that are observed. Normally, the radiography is not a single diagnostic tool. It should be combined with the history as well as the physical examination to reach at a final diagnosis. Now, the good quality radiographs may provide valuable information that is often sufficient to obtain a tentative or even definitive positive or negative diagnosis. And for the interpretation, the radiograph should be of good quality and proper exposure should be made of the area to be evaluated, and at least 2 orthogonal views at 90 degree angle to each other must be there. Why two orthogonal views at 90 degree angles are needed? Because the radiograph is a 2-dimensional picture of a 3-dimensional organ. When 2 views at 90 degree angles to each other, we can mimic a 3-dimensional image of the area to be radiographed. Now, the radiograph must be viewed by placing it on an X-ray viewer, also known as X-ray illuminator. The radiograph is placed in such a way that we should keep in mind that animal is in standing position and is facing us or the radiologist. That is, always place the radiograph in such a way that it corresponds to the normal erect standing position of the patient facing the radiologist. Now, for the placement of radiograph, the VD or dorsoventral view of skull, thorax or abdomen are placed in such a way that the anterior or cranial portion of the patient is upward, that is towards sky, and the caudal or posterior portion is downwards towards earth. The right of the patient is towards the left of the radiographer, and the left of the patient is towards the right of the radiologist. Now, for the placement of lateral views of skull, thorax, and abdomen. The radiograph should be placed in such a way that the cranial portion of the patient is towards the right of the radiologist and the caudal portion is towards in lateral view, the cranial portion should towards the left of the radiologist, caudal portion is towards the right of the radiologist, and the dorsal part of the patient is upward and the ventral part is downward towards the earth. Now for the craniocaudal or caudal cranial view of long bones or hind limb, the proximal extremity of the bone is upward and the distal extremity is downwards. The lateral extremity is towards the left of the radiologist and the medial extremity is towards the right of the radiologist. For the caudocranial or craniocaudal view of left fore or hind limb, the proximal extremity is upward, the distal extremity is downwards, the medial extremity is towards the left of the radiologist and the lateral extremity is towards the right of the radiologist. Lateral view, for the lateral view of right or left forelimb or hind limb, the proximal extremity is upward, the distal extremity is downwards, the anterior or dorsal portion is towards the left of the radiologist and the posterior or ventral portion is towards the right of the radiologist. You can change this position, but whatever radiographic position you take, you should always interpret the radiograph in that very position so that you can have the normal anatomy of the patient or the area to be radiographed in your mind so that you can diagnose a lesion whichever is seen on the radiograph. Now stereoscopic viewing is basically the viewing of a two-dimensional radiograph in a three-dimensional view. That is two orthogonal view at 90-degree angle to each other must be viewed so that you can make a three-dimensional picture. Now, a bright light falling on the front of the viewer or strong illumination around the viewing box must be avoided, and the spotlight is very important if you need to see a small area where the lesion is visible. Now, the interpretation of an X-ray film. Radiographic interpretation is both an art as well as a science. You cannot deny about the experience. The knowledge can never replace the experience. You must have sufficient experience of viewing and interpreting a radiograph to give a final diagnosis. Now, many other steps must be followed before giving your diagnosis. That radiograph should never be interpreted without access to complete medical history and signalement. You must know about the clinical signs, about the duration of clinical signs, any improvement, as well as the signalement. Signalement is very important. You must know the age, weight, breed, or sex of the patient. Like in very young animals, the abdominal contrast is very poor because of the poor fat content. So you see only black and white densities, the detail is completely lost. You must know that it occurs in young patients. Moreover, when you evaluate the long bones in case of young patients, sometimes you may say it is a fracture because the epiphyseal line is very clear. The metaphysis and epiphysis has a distance. So you must consider the age, weight, breed, and sex of the patient before diagnosing or before giving interpretation to a radiograph. Now, second step is a radiographic examination should be performed only after a clinical opinion of patient's health has been formed on the basis of detailed and complete physical examination. It is only after a detailed, complete physical examination that you diagnose that a particular system is affected, so that you can say that exposure of a cranial abdomen or exposure of a caudal abdomen should be made, whether lateral or VD view should be made, whether oblique view is also needed. So firstly, you make a tentative diagnosis of the area involved in your mind, then go for radiography, and then go for the interpretation. Next is the correct radiographic procedure should be practiced to obtain a good quality radiograph, because a poor quality radiograph is of no use. If you keep on repeating the exposure and the quality of radiograph is not good, you cannot give a final diagnosis. Another is evaluating the radiograph consists of identifying a lesion. If it exists, you should completely evaluate a radiograph either organ wise or area wise so that you can identify a lesion which is visible. Defining the location of lesion. Defining the location of lesion, you need to have two views, at least two orthogonal views. Then next is the classifying the lesion according to its raw antigen signs. There are 6 raw antigen signs, that is size, shape, margination, density, and contour. Whenever you identify a radiographic lesion, you assign these raw antigen signs before describing the lesions, then make a final diagnosis. Now, first is in determining whether an abnormality exists, the entire radiograph is evaluated organ-wise or area-wise. That means you should not miss even an inch of the radiograph. The whole of the radiograph should be evaluated completely before giving your tentative or final diagnosis. Another is the normal radiographic anatomy of the area must be available or must be known to the radiologist. You must know what is normal. Then only you can say if there is some abnormality, you can detect it. Next is to determine the anatomical location of a lesion. A minimum of 2 orthogonal projections at 90-degree angle to each other of any body part is needed. Now, then the lesion is classified according to its raw antigen sign that includes size, shape, number, location, margination, and tissue density. Now, Antony approach, that means immediate approach to jump at a diagnosis, it should always be avoided. Based on the lesion you identify, based on the changes, you make a list of diagnoses that may produce specific or that may produce similar lesions. Then combine the radiographic abnormality you detected with, correlate it with the history and clinical sign, and then give your diagnosis. That is known as gamut approach. Now, points to remember for radiographic interpretation. Air allows most X-rays through animal, resulting in a dark image. Fat is next, creating an image that appears lighter than air. Then lighter is fluid and soft tissue than fat. The structures that are very dense block most of the photons and appear white on the 12 film. And the interpretation is always done on a dry film. Now, errors in interpretation. Generally, when we get biased towards our diagnosis and we stop searching further after we get whatever whatever diagnosis we have made in our mind, we get that lesion, we stop searching for the rest of the radiograph. This should never be done because there may be many other lesions which you may miss just because of your Antony approach. Now, I have shown these radiographs just to show you the value of 2 orthogonal views. The first and second radiograph are the lateral and ventrodorsal view of a same dog. In the lateral view, you can see of soft tissue, abnormal soft tissue opacity in the cranial abdomen. You cannot say whether it is on left side or right side, but in the VD view, you can well appreciate that it is on the right side. Now, in the third radiograph, on the left side, you can well appreciate soft tissue opacity, which is an abnormality, which is not normal. In the fourth radiograph, you can well appreciate the increased radio opacity of kidneys and 2 radio opaque particles in the kidney, which are abnormal. Next is in the first radiograph, that is the VD radiograph, you may see certain radio opacities, small nodular radio opacities. You may say these are foreign bodies, these are metallic bodies, these are bony pieces, but in the later radiograph, you can well appreciate these were the teats of the dog, which were seen as radio opacities in the VD view. So third and fourth radiograph show a radio opaque circular area in the region of caudal abdomen. Sometimes in this radiograph, it is very clear that it is in bladder, but sometimes you may confuse that whether this radiopacity is in bladder or in intestine. For that, you can take the VD view. And in VD view, you may correlate whether it is in the bladder or in the intestine. And moreover, with the you correlate your findings with the clinical symptoms and then give your diagnosis. Now, next come to the ultrasonography. As we all know, the sound is the mechanical energy in the form of pressure waves, and it needs a medium to transfer. Now, ultrasound is the sound waves above the audible range of human being. Normally, we human being can hear the sound waves of frequency ranging from 20 to 20,000 hertz, and the frequency more than 20,000 hertz we cannot hear, and which is known as ultrasound, and it is used in the medical imaging. And normally in medical imaging, we use the ultrasounds of frequencies 2 to 15 million hertz. Sometimes we use the ultrasounds of 50 to 100 megahertz for the diagnosis of superficial structures, that is in case of eyes, as well as for the subcutaneous lesions. We use the frequency range of 50,000 to 50 to 100 megahertz. Now, this ultrasound is basically based on the pulse echo principle. There are certain materials, also known as piezoelectric crystals, which have the inherent tendency to change their shape and produce sound waves whenever they are stimulated. So they have the inherent capacity. So these are known as piezoelectric crystals. When they are stimulated, they produce sound waves in the form of a pulse. When this pulse is directed through tissues, they interact with the tissues and produce echoes. These echoes then again go back to the transducer, again strike with the piezoelectric crystals, which are again stimulated, and they produce the impulse, which is converted into electrical signal, and that electrical signal is displayed on the screen as the image of the area being ultrasonographed. I will repeat again. There are piezoelectric crystals which get stimulated when electricity is passed through them. When they get stimulated, they emit sound waves in the form of pulse. When these sound waves or pulse interacts with the tissues, some of the sound waves they are absorbed, some are reflected, and some are refracted. The sound waves which are absorbed, they are used for therapeutic purpose. The sound waves which are reflected back to the transducers in the form of echoes, they again stimulate the piezoelectric crystals, which give a current, and which that electrical energy is converted into the image which is displayed on the screen. Now, the types of transducers used in the ultrasonography. The ultrasonographic transducers, also known as probes, are of different shapes, sizes, and with diverse features. These transducers can be either external transducers or internal transducers. External transducers, which are used on the external body surface, and the internal transducer, which can be used on the internal organs, like we have parectal transducers. The ultrasound transducers differs in their construction based on the arrangement of piezoelectric crystals, aperture or footprint. Footprint is the area which comes in contact with the body wall when we do ultrasonography, and frequency. They may have a single frequency, or they may have broad bandwidth which can emit frequency of various ranges. Now, there are mainly three basic types of probes which are used in the veterinary medicine, that is linear, in which the piezoelectric crystals are arranged in a rectangular fashion; curvilinear, in which the piezoelectric crystals are arranged in a curvilinear fashion; and phased array, in which the footprint is very small and a single piezoelectric crystal rotates in a fan-shaped manner to produce sound waves which can penetrate deeper and to a wider area. Now, these are the photographic representations of linear or phased array and curvilinear transducers. Generally, the linear transducers, they are of high frequency. They are used for the superficial imaging. The sector or phase array, they are of low frequency and they are used for the deep imaging. And curvilinear array, they have wide bandwidth and they are used for the intermediate, that is 2 to 6 centimeter thickness. Next, another picture showing the sector, linear and curved transducer and their image area. Now about the transducer frequencies. Normally I told you we use the frequencies ranging from 2 to 10 megahertz. The ultra high frequency, that is 50 to 100 megahertz, is used for the ocular ultrasonography as well as for the sonography of superficial or subcutaneous lesions. The higher is the frequency, the lesser is the penetration, but more is the resolution. Lower is the frequency, deeper is the penetration with less resolution. Generally, we use 7.5 megahertz transducer for a thickness of up to 4 to 6 centimeter, 5 megahertz transducer for thickness up to 10 to 12 centimeter, 3.5 megahertz transducer 15 to 20 centimeter thickness, and 2.5 megahertz transducer for thickness up to 25 to 30 centimeter. Generally, in veterinary radiography, we use the 3.5 megahertz transducer in case of small animals, 2.5 to 3.5 in large animals, and 7.5 megahertz in case of small breed dogs. Now the modes of echo display. Echo is whatever the pulse is interacted with the body tissue and whatever information they contain is displayed in the form of echo display. There are three modes of display, that is A mode, B mode, and M mode. A mode is the simplest form of display. It displays two parameters. The horizontal line shows the distance from the transducer and the amplitude is depicted on the vertical line. Amplitude of echo means higher amplitude echo we get from the denser tissues. Now B mode, that is brightness. The information of amplitude of echo is presented in the form of brightness of dots on the screen. And M mode, this is the real-time scanning that records the position and motion of echo. The images are moved along the horizontal axis, showing the movement of structures along with it. Now, this is the photographic image, that is A mode. It will give amplitude in the vertical direction and distance from the transducer in the horizontal direction. B mode displays a white image against a black background. In M mode, we can see the motion as well as the distance from the transducer. This is again the M mode, which will show the motion and position of the echoes. Now about the scanning procedure. Before going for the scanning, the patient is very important in ultrasonography, because without patient preparation, you cannot scan a particular organ. The scanning procedure involves clipping of hair, that the area should be devoid of dirt and dust. Application of coupling gel. The coupling gel is basically applied to have proper contact of the transducer with the body wall. There should not be any entrapment of air between the transducer and the body wall. If the air is entrapped, air is hyperechoic, it will not allow the pulse to move further and no image will be seen beneath the air. So air should be avoided in ultrasonography. Close contact and patient cooperation, because ultrasonography we are doing real-time imaging, so it may take time. A single image is no image in ultrasonography. We need to scan the organ in different planes at different angles so that we can assess the whole of the internal architecture of that very particular organ. So it takes time. So patient cooperation is very important, and the scanning expertise. Scanning expertise is very, very important in ultrasonography, because you need to know what is normal, and there is variety of ranges in different breeds, in different sizes and different age groups. So you must know the normal anatomy for all the species of all the age groups, so that you can give a correct diagnosis. Now about the image interpretation. I told you ultrasound images are usually displayed as white against a black background. The image may be hyperechoic or echogenic. hypoechoic. These terms are used for the diagnosis or for giving the report of ultrasonography. Hyperechoic means you have bright echo or white echoes. Hypoechoic means you have less bright echoes than hyperechoic. Anechoic means you have black area. And isoechoic means the echogenicity is similar to the adjacent area. Now, this is a pictorial presentation of hyperechoic. This round portion is hyperechoic than the surrounding tissue. Now, hypoechoic, the circular portion is lighter than the or blacker than the surrounding tissue. Isoechoic means similar echogenicity to the surrounding tissue, and anechoic means completely black. In contrast to radiography, air produces hyperechoic echoes in ultrasonography, whereas in radiography, air gives you black image. So it must be remembered that air is enemy of ultrasound and friend of radiography. Now again, this anechoic means completely black. This anechoic image may be of gallbladder or urinary bladder. Hypoechoic means less dark, and less bright, and hyperechoic means more bright. Hyperechoic images are of denser tissues, you can say spleen, and hypoechoic may be liver or a mass. Now, artifacts. Artifacts are basically non-real images. They are not the echoes from the actual area which were sonographed. These are the non-real images. So these artifacts may hinder your diagnosis. You must be familiar with the appearance of these artifacts. Just by moving the transducer or changing the position or angle of your transducer, you can appreciate whether this is an artifact or it is a real image. Certain artifacts encountered in ultrasonography are reverberations. They are seen with metallic objects as well as air. Mirror image, that means same area is imaged at two sides. This is seen at very highly reflective surfaces, like sometimes gallbladder can be seen beyond the diaphragmatic line. This is the mirror image. Acoustic shadowing. Acoustic shadowing is whenever ultrasound encounters a highly reflective surface which reflects almost all the echoes, all the pulses back to the transducer in the form of echoes. No pulse can go beyond that hyperreflective surface. So area behind that hyperreflective surface appears black. That is known as acoustic shadowing, and this is very important artifact in diagnostic imaging. We can diagnose the presence of stones or mineral densities in soft tissues. Then next is edge shadowing. Edge shadowing is seen in the curvilinear areas where there are anechoic areas beneath the edges of a curvilinear structure. Now, acoustic enhancement. Actually, in ultrasonography, we consider a general principle that ultrasounds travel at the same speed in all the tissues of the body, but it is not there. Their speed of the propagation is different in different tissues. So if ultrasound pass through urinary bladder and to the surrounding soft tissue, the more number of ultrasound wave will reach to the caudal distal end of a cystic structure as compared to a structure which is adjacent to it, which has a more number of ultrasound waves, ultrasound pulses. So the area beneath a cystic structure or a fluid-filled cavity will appear more bright. That is acoustic enhancement. Side lobe artifact results when the ultrasound beams originating from the side lobes of the transducer, they are placed in the area of central ultrasound beam. In that case, we can see a sludge in anechoic areas. Now, beam thickness, beam width, or slice thickness artifact, it occurs when half of the transducer is on one part and half of the transducer in some other organ. And the image image of both the parts is displayed in a single image. In that case, we encountered this beam width artifact and propagation of speed error. As I told you, the ultrasound waves travel at different speed in different soft tissues. So whenever an area which is beneath two portions, one portion which in which the ultrasound waves travel at a faster speed, and adjacent area in which the ultrasound waves travel at a lesser speed, the area where the ultrasound waves will reach first will be depicted closer to the transducer as compared to the area where the ultrasound waves reach later. So there you may see a discontinuity in a linear structure. For example, sometimes we see discontinuity in the diaphragmatic line, sometimes discontinuity in the intestinal wall, but by changing the position of transducer, you can well avoid these artifacts. Now, these are reverberations. These are the pictures of reverberation which you normally encounter in case of metallic foreign bodies. Now, mirror image, you can see this gallbladder is visible on both sides of the diaphragm. Acoustic shadowing, that is the highly reflective surface blocking all the sound waves. So, anechoic areas beneath this hyper reflective surface is seen. Edge shadowing, this anechoic area at the edge of a curvilinear fluid-filled cavity. Slice thickness, two parts are shown on a single image. Comet tail seen with the gas in the intestines or stomach. This is again acoustic shadowing. Propagation of speed error, where you see the discontinuity in the diaphragmatic wall. Now, in general, in ultrasonography, liver has homogeneous coarse granular echogenicity. Spleen has homogeneous fine granular echogenicity. In kidneys, cortex is hyperechoic than medulla. Urinary bladder is seen anechoic. Gallbladder is seen anechoic in the liver, and lymph nodes are hypoechoic than the surrounding tissues. All these terms are relative only. We compare the echogenicity of organ with the adjacent organ. So these are the relative terms, and generally spleen is hyperechoic than liver, and liver may be hyperechoic or isoechoic to kidneys in case of dogs. Now, normal images, you can say first image is of liver along with gallbladder. You can see the coarse granular echogenicity of liver and anechoic gallbladder. The second image is of spleen and kidney. Spleen is hyperechoic to cortex of kidney. In third image, the right kidney and liver can be seen. And in image, the prostate gland at the neck of bladder can be seen. You can see the prostate gland has hyperechoic echogenicity. Now, applicability of ultrasonography in veterinary medicine. Earlier, the ultrasonography were used only for the pregnancy diagnosis in small ruminants also, but with the advent of the advancements in the ultrasonographic imaging, now the diagnosis of many abdominal organ diseases like reticular diseases, liver, spleen, kidney, intestine. So all these organs can be imaged and their disorders can be diagnosed. Urethral calculi can be diagnosed easily. Diagnosis of diaphragmatic hernia can be done by ultrasonography. Diagnosis of ocular diseases, diseases of adherent teeth, and the tendon rupture and its healing can be well appreciated using ultrasonography. Now, advantages of ultrasonography. It is a non-invasive technique, so it has no radiation exposure, so can be repeated many times without causing much discomfort to the patient. It does not require general anesthesia or sedation, provides information about the size, shape, location of structure, and internal architecture of the organ, can be able to differentiate soft tissue and fluid-filled structure, which is not possible with the radiography. It is generally recommended in the diagnosis of chronic diseases, can be used for the identification of foreign bodies, and it permits accurate fine needle aspiration or biopsy of tissues for the disease diagnosis. Now, limitations. The ultrasonography is highly dependent on the experience and skill of the operator. Its inability to penetrate gas filled or bony structures. So any structure beneath the gas filled structure or beyond the bony structure cannot be seen. So abnormality of that area cannot be diagnosed. Artifacts may lead to misinterpretation. It allows no real appreciation of skeletal structures except for bony surfaces. It is impossible to attribute changes in ecotexture and ecogenicity to certain pathophysiological causes. This means it is non-specific for disease diagnosis. It will diagnose the changes in the internal architecture, but it will not reveal the cause. The equipment can be expensive, or you can say the initial cost of investment is high, and considerable time is required to master the ultrasound. And one thing you must know, that air is enemy of ultrasound and friend of X-ray. Thank you very much.